It's 7 o'clock. Nurullah, we can start.
Yes, okay. Good evening, good afternoon, or good morning, wherever you are in the world. Welcome to our online conference today. Before giving the floor to our dear guest, I want to introduce our team. I will be the moderator of today's conference. My name is Dr. Nurullah Kösmene. I am one of the residents of the Neurosurgery Department of İzmir Training and Research Hospital. These online education meetings have started with Associate Professor Hasan Kamil Sucu. He is the Program Manager of the Neurosurgery Department of İzmir Training and Research Hospital, and goes on with the contributions of all the residents, also with the contributions of the neurosurgeons who graduated from the same department. I kindly ask you to keep your microphones turned off during the presentation of the lecturer to avoid voice and noise pollution. You can ask your questions not by turning on your microphones, but by writing to the chat part of the Zoom program. At the end of the presentation, your questions will be asked to the lecturer and will be discussed. Mutual discussion is not appropriate for the format of our meetings. Please do not ask for your microphone to be turned on. And now I would like to introduce our dear guest. It is my privilege to present our lecturer, Professor James Thomas Rutka. And I am very excited today, and I think all of us are very excited. Today we have an admirable guest, a giant for neurosurgery, a guest who should be role model for all of young neurosurgeons like me, and also for the students following us. Welcome again, Professor Rutka. I want to screen share. Just a minute. Could you see my screen?
Yes.
Screen? Yes, okay. Dr. Rutka was born in 1959 in Toronto. He studied chemical engineering at Princeton University before obtaining his Doctor of Medicine from Queen's University in 1981. After that, Dr. Rutka did an internship at McGill University before entering the University of Toronto Neurosurgery Training Program in 1982. His training included a research fellowship at the Brain Tumor Research Center, the University of California, San Francisco, where he obtained his PhD in experimental pathology in 1987. Dr. Rutka completed a clinical fellowship in microvascular neurosurgery with Kenichiro Sugita at Nagayo University. After that, he did a postdoctoral research fellowship in molecular immunology under the supervision of Ko Okumura at Juntendo University in Tokyo in 1990. This photo I took from Professor's Instagram. The photo was taken at Kiyomizudera in Kyoto in the year 2015. And he says that last time here was 25 years ago. Dr. Rutka joined the Department of Surgery in the Faculty of Medicine at the University of Toronto in 1990. He was appointed to Sick Kids Hospital, where he contributed to a variety of techniques to treat children with neurosurgical conditions. He also established the first brain tumor research laboratory at Sick Kids, focusing on the molecular biology and genetics of pediatric and adult brain tumors. In 1997, and in collaboration with his colleagues in Toronto, Rutka was influential in establishing the Arthur and Sonia Labatt Brain Tumor Research Center, at Sick Kids. Now it is one of the largest centers of its kind in the world. In 1999, Dr. Rutka was appointed professor in neurosurgery in the Department of Surgery and the then family professor and chair of the Division of Neurosurgery. This is a position he held until 2010. Currently, Dr. Rutka is the R.S. McLaughlin Chair of the Department of Surgery at the University of Toronto. He is a pediatric neurosurgeon whose clinical practice has been at the Hospital for Sick Children. Dr. Rutka's primary research and clinical interests relate to the science and surgery of human brain tumors, epilepsy, craniofacial anomalies, and congenital malformations. He has over 500 peer-reviewed publications. In 2009, he was the honored guest at the Congress of Neurological Surgeons annual meeting. In 2010 and 2011, Dr. Rutka served as president of the American Association of Neurological Surgeons. In 2011, he became president of the World Academy of Neurological Surgery. In the same year, he served as president of the American Academy of Neurological Surgery and fellow of the Royal Society of Canada. That same year, he was appointed as the R.S. McLaughlin Professor and Chair of the Department of Surgery at the University of Toronto. In 2013, he became the first Canadian to be appointed as editor-in-chief of the Journal of Neurosurgery. And that year, he was inducted as a member of the Order of Ontario. We see the editors of Journal of Neurosurgery in this picture. Dr. James Rutka is second on the left. In 2015, he received the Margallos National Brain Disorders Prize from the University of British Columbia. And the same year, he received the Robert L. Noble Award from the Canadian Cancer Society. And that year, he was made an officer of the Order of Canada. In 2017, he received an honorary degree, Doctor of Science, from his medical school, alma mater, Queen's University. In 2019, he received the Cushing Medal from the IAEH, the highest honor that can be bestowed on one of its members. Dr. Rutka played numerous sports in high school and university. He set the Canadian midget triple jump record in 1972. In high school, he was drafted by the Peterborough Pete's hockey team, but he chose instead to attend Princeton University to study chemical engineering. At Princeton, Dr. Rutka played varsity football and ran track and field. In medical school at Queen's University, Rutka was quarterback of the varsity football team that won the Vanier Cup in 1978 against the University of British Columbia. Dr. Rutka is married to Marie Rutka. Together they have 3 children, Danielle, Hannah, and Marisa. And finally, today we have heard some sad news about another giant of neurosurgery, Fred Gentili. I am guessing he was your colleague at the University of Toronto. I know that all neurosurgeons in Turkey, especially those who have met him personally, are upset. We feel sorry for your loss. Rest in peace, Fred Gentili. And welcome again, Professor. The microphone is yours. You can start share. Welcome again.
Well, thank you, Dr. Cosmine, for that very kind introduction. Also for your kind words about Dr. Gentili, who is a colleague, a tremendous neurosurgeon known throughout the world for his efforts in skull base and pituitary surgery. Sadly, he passed away from glioblastoma just 2 days ago. And I want to thank Professor Suchu also for the kind introduction to attend this particular meeting with you today, all the way in İzmir, and I am, of course, in Canada. But I do have a Toronto, Turkey connection. I've been to your country many times for a number of different meetings, and I've actually been to İzmir. I'm sorry I can't be with you in person today, but I have been to İzmir, a beautiful city, and on the way to İzmir, stopping in such places as Pergamon, Asclepius, Aphrodisias, and a variety of other very historic sites within Turkey. So you have a beautiful country. I've been there many times, as mentioned, and would love to come back again once the pandemic is finished. Today I thought I would talk about hemispherectomy. This is a very challenging surgery, probably the most difficult procedure that I do in neurosurgery, among the most challenging in all of neurosurgery. And it has a very interesting history. The very first hemispherectomy, as described, was performed by Dandy in 1928, and he performed the procedure in a patient with glioblastoma. And despite removing the hemisphere, there was still a problem with recurrence of the tumor, and as a result, this was no longer continued into the future. But in 1938, a decade later, Mackenzie performed a hemispherectomy on a patient with epilepsy who lived a very long and gratifying life after the hemispherectomy. And this was the first one performed for epilepsy. And interestingly, Mackenzie was the very first chair of neurosurgery at the University of Toronto, and he was trained by Harvey Cushing. That was an anatomic hemispherectomy. Over the years, what happened was a evolving technique of reducing the amount of brain tissue that needed to be removed in performing more in the way of a functional hemispherectomy, as described at first by Rasmussen. And then Vilmur published his results on peri-insular hemispherotomy. He was at McGill in Montreal, and I went there to learn his technique about that time. Dr. Ben Carson, a neurosurgeon from Baltimore, described his technique of hemidecortication, which is a very valued technique, probably not used very much these days, but was a good way to stop seizures in selected children. In 2007, Delalande from France introduced the vertical parasagittal hemispherotomy procedure, and many groups have adapted this particular procedure. This is a photograph of Harvey Cushing, and to Harvey Cushing's right is K.G. Mackenzie. So as mentioned, the very first chair of neurosurgery at the University of Toronto, trained by Cushing. So we like to believe in Toronto that we are descendants of Harvey Cushing. A little bit more of the history. Anatomic hemispherectomy gradually fell out of favor because of some of the side effects, which I'll refer to subsequently. And then in the 70s, Rasmussen developed the functional hemispherectomy. And at the very end, I'll talk about subtotal hemispherectomy, which is a new technique that is performed to try to preserve function in some patients who have intractable epilepsy. Just a few words about hemidecortication. This is where the brain is largely removed lobe by lobe, so lobar resections, resecting the cortical gray matter, leaving the white matter. This prevents blood from entering into the ventricular system. The trouble is, in some cases, especially like hemimegalencephaly, there will be some blood loss. It can be hard to control at times. And it's really difficult to completely disconnect the hemisphere using this technique. and long-term seizure frequency control is not as good as with other techniques in the order of 50 to 80%. I've done several of these hemidecortication procedures. I actually consider doing it in select cases of children with Sturge-Weber syndrome, but rarely these days will I use hemidecortication technique. This is what it looks like, where you remove, essentially, if you can see my cursor, you can remove the gray matter of the brain, and hence you have multi-lobar resection occurring. And this is what the postoperative picture looks like. This is the middle cranial fossa here, the anterior cranial fossa here, and you can see what the residual brain tissue looks like, preserving the deep gray matter of the brain, of course. Well, what are the indications for hemispherectomy? One is all of them are actually for diffuse hemispheric disorders, but one is Sturge-Weber syndrome, which I alluded to already, cortical dysplasia, hemimegalencephaly, Rasmussen syndrome, porencephalic cyst, and hemiconvulsion hemiplegia epilepsy syndrome. These are some images taken from the types of children on whom we would operate. So hemimegalencephaly is here. You can see the distorted cerebrum on this side. Sturge-Weber is here. You can see the leptomeningeal calcification and enhancement that occurs. This is Rasmussen's encephalitis, where you have essentially atrophy of one hemisphere of the brain. And this is cortical dysplasia, where the entire cerebrum typically is abnormal, but on one side of the brain. There are some less common indications, and I've operated on children who have had polymicrogyria, post-traumatic brain injury, low-grade brain tumors that have been recurrent, unilateral ventriculomegaly, West syndrome, Lennox-Gastaut. These are other less common indications for hemispherectomy. When you're thinking about planning your surgery, you have to understand the neuroanatomy. So that includes the ventricular size. When the ventricles are small, like this makes this procedure very challenging if you're doing a functional hemispherectomy. I always look at the Sylvian fissure because essentially a lot of the procedure is performed just above and below the Sylvian fissure. We look for the circular sulcus, which is an entry into the ventricle. Thickness of the corpus callosum is key because sometimes it's very thin, other times it's very thick. Parenchymal atrophy will help with your dissection. And if there's abnormal vasculature, as occurs with Sturge-Weber, then you may wish to choose a different approach or be very careful as you embark upon hemispherectomy. So when's the best time to do surgery? This is still debated, but typically now we think the sooner that you've demonstrated catastrophic epilepsy and intractable epilepsy, the better. So after ages 6 to 8, the dominant hemisphere is unlikely to shift to the contralateral side. So this supports earlier surgery. You have a higher success rate the earlier you do the surgery from the time of seizure onset. And early seizure surgery allows for control and optimizes the psychosocial development. And I've done hemispherectomies as young as 2 months of age, which is technically quite a challenging situation. Of the techniques for hemispherectomy, anatomic is here, but over the years what's happened was we've gone from removing large portions of brain to removing smaller portions of the brain to perform functional hemispherectomy, perisylvian hemispherotomy, transsylvian, and then finally the vertical hemispherotomy, going from partial disconnections to more extensive disconnections and having large removal of tissue versus minimal removal of tissue, as in these cases here. So the technique that I'll speak about mostly is the perinsular hemispherotomy technique, and these are the steps 1 through 7, superinsular, infrainsular windows, temporal lobectomy or temporal disconnection, coronal radiata transection, callosotomy, frontal basal disconnection, and insular resection are all part of the procedure, and you do these stepwise in order to disconnect the hemisphere. If you're doing these operations, you really must understand the anatomy. And here's the suprainsular window. Here's the infrainsular window, the pericallosal arteries, the corpus callosum, and the ventricles. All of these are key features for success in this procedure. Anatomically, as you separate the frontal and temporal opercula, of course, you expose the insular cortex. And in epilepsy surgery, we do this quite often, but in other forms of surgery, you may not see or have an opportunity to expose the insular very often in neurosurgery. Certainly with gliomas, both high-grade, low-grade gliomas, this can occur with exposure to certain arterial venous malformations and so on. Yes, you can, but it really is in the domain of the epilepsy surgeon in order to see the insular cortex, as is shown here in these anatomical images. Temporal lobectomy, I don't need to describe that to you, but here you can see the choroid plexus of the temporal horn. This is now the atrium and then going into the frontal horn. And what you're seeing here is the hippocampus, and you really have to disconnect the hippocampus in order to do this procedure successfully. I've always added in a temporal lobectomy, although it's not totally mandated, just because sometimes after hemispherectomy there can be some cerebral swelling, and to have room in the middle cranial fossa helps with the postoperative management of these children. The corona radiata transection is really what causes the hemiparesis if the hemiparesis has not been fully formed prior to surgery. And what you're seeing here is cutting around, this is the insular cortex here, but cutting around the insular cortex. And that was what will create not only the hemiparesis, because here's the corona radiata, but it also gets you into the ventricle, which is a key step to find the pericallosal arteries in order to do the callosotomy. So in these stepwise diagrams, you can see how it's important to enter the ventricle and to cut across the corona radiata, which immediately causes the hemiparesis or worsened hemiparesis in children with hemispherectomy. And then the callosotomy. So over the years, I've just learned that in order to find the pericallosal vessels from the unilateral ventricle, approximately 1 centimeter or so above the foramen of Monro, which is shown here, and going vertically upwards, and then exposing the septum pellucidum at the junction of the corpus callosum, that's where you'll find the pericallosal vessels. And sometimes navigation is useful, but I would say most of the time I don't use navigation for, or rely on navigation for hemispherectomy. But I think in your early cases, if you have navigation, it will keep you on track, because that's one of the maneuvers that can be one of the most challenging parts of the procedure, is finding those pericallosal vessels to know that you've come across the corpus callosum. So I do have a video. I hope it plays here. We'll see sometimes videos overseas can be choppy because of the bandwidth and connection. But here we are just at the junction of the septum pellucidum and the corpus callosum. We'll be opening up here, and you'll see we'll come across the vessels, the pericallosal vessels. The foramen of Monro is down here. And I'll just let this video play. And this is a child, obviously, with a large ventricle on one side, which makes the dissection quite easy. Now we've found the pericallosal vessels, and you can see them here. And essentially, you just follow those pericallosal vessels anteriorly and posteriorly, expose them. And by virtue of doing that, you know that you've cut across the corpus callosum here. Now, the callosal vessels are curving downward anteriorly across the rostrum of the corpus callosum. And this is a very nice way to ensure that you've completed your callosotomy. And you've got to do this all the way down. Where there are recurrences and residual of the corpus callosum, it's usually in the rostrum in my experience. So take time to completely disconnect at the rostrum, I would say. And then heading back posteriorly, you just keep going, following. And then what happens is the pericallosal vessels will merge with the falx, and I'll show you that later. But once you find the falx, you can follow the falx to the tentorium, and that will be your posterior disconnection. Okay, so here you can see the callosotomy that's being performed around the corpus callosum, finding the pericallosal vessels, staying essentially right on target with those, and then you know you've completed your corpus callosotomy. This is now the posterior disconnection. I'll hope that this video plays as well. So now we've transitioned from finding the pericallosal vessels to seeing the falx. The free edge of the tentorium and the falx is being shown here. And by following this all the way down through the structure that's called the calcar avus, you can disconnect everything that lies behind the ventricle, the temporal horn, and this will be a nice posterior disconnection that will allow you to ensure that there's no connection from occipital lobe, part of the parietal lobe, and heading ventrally and across the corpus callosum. So this is done stepwise and is a nice strategy to disconnect. And the other key feature of this is you have to save the branches of the posterior cerebral artery which come over the tentorium, because to take those will cause an infarct that you'd like to avoid, because that causes brain swelling after the procedure. The next step is frontal basal disconnection. Here's the frontal lobe seen from its base, and essentially the cut line is like this, or perhaps a little bit further back this direction. And this allows the frontal lobe to be disconnected from everything else and to prevent any passage from frontal lobe fibers across the corpus callosum. Here's a video of the frontal basal disconnection. And just to point this out, the sphenoid wing is down here where this retractor is situated over here. And this is a vessel that's coursing across the frontal lobe. And this is the disconnection that goes all the way subpial down across the sphenoid wing, staying at the sort of the edge of the sphenoid wing as you come across, and you come down subpial until you find your pericallosal vessels, and then you know that you've disconnected the frontal lobe from connecting across the corpus callosum. So this is a very important step, the frontal basal disconnection, and keeping the peel border intact allows you to ensure that you've stayed appropriately on target and that you don't go to the contralateral side. All right, so those are the steps for hemispherectomy. Seizure control, anatomical hemispherectomy, good, about 80 to 90% control, but there have been some downsides to the hemispherectomy, which I think we'll talk about. Peri-insular hemispherotomy, about the same Engel class outcomes. And in my experience, the better outcomes are with Sturge-Weber, Rasmussen's encephalitis, and peri-middle cerebral artery infarct syndrome. Motor outcome for these children, if they have a preoperative hemiparesis or hemiplegia, they won't be worsened typically after the procedure. Some will actually improve afterwards, as has been my experience. In our experience, we had early on 20 patients, and most of them had a preoperative hemiparesis. All of them had it postoperatively, but 18 of the 20 remained ambulatory, which is one of the goals. We'd like to make sure that our patients after the surgery can ambulate. Complications for anatomical hemispherectomy. The mortality was quite high, usually because of blood loss, CSF leak, wound infections, hematomas, blood loss, infarcts, brainstem distortion, sagittal sinus thrombosis, superficial siderosis was a problem, and that's one reason why anatomical hemispherectomy is not performed so much nowadays. But for hemispherotomy, the mortality is quite a bit less, and similar to the anatomical procedure, the complications are similar, but the blood loss is less, and there's less need for VP shunting after surgery, in my experience. So here's one of our papers, Hemispherectomy for the Control of Intractable Epilepsy in Childhood, comparison of two surgical techniques. we looked at these two techniques, and for the peri-insular hemispherotomy, we had 85% seizure freedom control. But with the hemidecortication technique, which we used early on in the 1990s, the result was not so good, about 50% seizure freedom. So clearly, as mentioned at the beginning, hemidecortication is not the technique that is most promising for seizure outcome. I'm going to show you a couple of cases now. The first one is a 2.5-month-old, so very young child, female baby with seizures. Catastrophic epilepsy, that's the term that we use to describe how this epilepsy appears. This child was in constant seizure state, so status epilepticus. And there was no way to get the child out of this seizure problem unless we did the surgery. So at 2 months of age, we ended up doing this procedure. Already at 2 months of age, there was a demonstrated hemiparesis. We showed the MRI scan to you here because sometimes the abnormality is a little bit subtle. As you can see here, you need at times a neuroradiologist to point out the area of abnormality. But if you look here at the left side of the brain in this region compared to the other side, you can see changes in myelination that occur here that indicate that this is hemimegalencephaly compared to the other side. But it can be fairly subtle. And unless you have a very good neuroradiologist, sometimes you may not pick up these particular findings. So this was the abnormal hemisphere. We went off to do surgery. And here we go, and you can see the cut across here. This is the frontal basal disconnection. This is the posterior disconnection. This is the preserved deep gray matter here. We've already resected the insula. And this is what it looks like after the surgery. And if you wait several months after the surgery, this is what it looks like. You get obviously some cavitation, and you can see the cut that goes right to the pericallosal arteries here. This is the frontal disconnection. The frontal lobe is isolated here. The insula has been resected. Deep gray is preserved, and now the posterior segment of the brain is disconnected. You can see from this cut across here. This is what it looks like on coronal section, and the callosotomy can be seen right there. Okay, the next case is an 18-month-old boy who had transposition of great arteries but had left middle cerebral artery infarct syndrome and seizures beginning at 8 months of age, 3 types: infantile spasms, hypomotor, and simple motor seizures. Clinically, these seizures were affecting this child, but you can see that the upper extremity is preserved, and he was able to vocalize. So an older child, 18 months of age. This is what the brain looked like. You can see the infarct that had occurred, and this is one of the good indications for hemispherectomy. These children already have a hemiparesis, and so they're not made any worse by doing the surgery in terms of their motor outcome. This is what the brain looks like. If you're interested, prior to the surgery, you can see the surface anatomy where the infarct is found. Of course, this is the temporal lobe here. You can see the central region, the Rolandic area, and this is what it looks like after the surgery. So you can see that a lot of the brain tissue is preserved after hemispherectomy, and we're not doing anything remotely like an anatomic hemispherectomy, which removes all parts of the hemisphere in terms of the lobes of the brain. And this is after the surgery. You can see the cuts that we've made, the frontal basal disconnection, the posterior disconnection, insular resection, preservation of the deep gray. And so this is how the procedure goes. Just a word about tractography. It's a reliable technique for tracing the white matter pathways. Diffusion tensor imaging allows for the motion of the water and the voxel levels to be preserved. And it's a way for us to know if there are any crossing fibers going from one hemisphere to another. So here's an example of a 6-year-old male. Sudden onset of right hemispheric seizures. Diagnosis was Rasmussen's explosive epilepsy. He underwent hemispherectomy, and he was seizure-free for 8 years. And then his seizures recurred, right-sided seizures, and his diffusion tensor imaging showed us still a small area of connectivity. And here on this MRI scan, you can see where the arrows are pointing and where the DTI is situated. There's crossing fibers that we must have missed at the time of the original surgery in the rostrum of the corpus callosum, which is typically the place where I see persistent connections after hemispherectomy. But I want to show you this child because this child was 6 years old at the time of the surgery, and I want to show you how functional he was after hemispherectomy. So he was a normal child prior to epilepsy starting from Rasmussen's, and then he had his epilepsy surgery, hemispherectomy, and this is what he looks like now. And this is a video showing him on skis, skiing in Canada. You can see here. There he is, going down the hill skiing.
Turn it up.
Here he is scuba diving. Here he is water skiing at a young age, about a year or two after hemispherectomy. And he's a good golfer. He's a one-armed golfer, and just an amazing, spectacular recovery. And here, many, many years later, this is him waterboarding, as you can see here. And you can see the hemiparesis on the left side, but spectacular recovery after hemispherectomy. As mentioned, a very good golf player with one arm. So these kids can be highly functional. So we use the DTI information to find that small area of connectivity. And this is the procedure on what it looks like after you go in again, just to section that small area of connectivity, persistent connectivity. And with this result, this operation itself takes about 20 to 30 minutes after the craniotomy. And you can get the child back into a seizure-free state. So they're the pericallosal vessels you can see here. And the procedure was just to complete the hemispherectomy by doing the small attachment. But that child was seizure-free for 8 years prior to recurrence. There are some limitations to every operation for the perinsular hemispherotomy. Young children, so as mentioned, I've operated as young as age 2 months. That's pretty early. You have to know the technique quite well before embarking on hemispherectomy at that age. If you're just starting this procedure, I would recommend starting with a case like middle cerebral artery infarct syndrome or large ventricle as opposed to a small ventricle. It's just that it's a little bit tricky with the ventricular anatomy and finding the pericallosal vessels if the ventricles are small. DTI can help identify residual connectivities if you have failures. Failures are about 10%. Repeat craniotomy is usually straightforward. Seizure freedom can be regained again. The occipital and frontal lobe infarctions can occur if you take the branches of the as I mentioned to you, the posterior cerebral artery. You can sometimes get infarctions, frontal lobe as well, and if they cause mass effect after the hemispheric procedure, you sometimes have to do a lobectomy and go back in and remove the swollen, infarcted part of the brain. So you have to be careful by preserving as many of the crossing vessels as possible. The brain will sink in a lateral approach like this, so it's sometimes better to think about a vertical disconnection. That's the Delalande procedure, the vertical parasagittal hemispherectomy. I won't be speaking about that today, but a number of groups are using that technique, and so on. So in this last minute or two, what I want to do is just to describe for you a fairly new technique that has arisen in the last few years called subtotal hemispherectomy. And this is done to preserve the Rolandic area or the cortical spinal tract. And the steps of the procedure are very similar to what I described to you, with the exception of leaving intact the cortical spinal tract and its crossing. So there's a frontal basal disconnection, a callosotomy, a complete if possible, but it just sometimes can't be possible. I can tell you from experience. sparing the Rolandic cortex, or the functional part of the brain, so that a hemiparesis won't be present after surgery, a partial insular resection that you can perform, a posterior disconnection that can be done. And this is done in children that are high functioning, in whom you don't want to have a hemiparesis. So if a child doesn't have a hemiparesis to begin with, but it looks like it's diffuse epilepsy, but perhaps the central region of the brain is not involved, you can do a subtotal hemispherectomy. But I'd say that the long-term results in these cases are still pending. This is a 5-year-old male that we decided to do a subtotal hemispherectomy on. He was 5 at the time of his original surgery, where we did an extensive temporal lobectomy. And he was seizure-free for many, many years, I think 7 years or something like that. But then his seizures came back. You can see his scar from his previous temporal lobectomy. So we ended up doing stereo EEG to find out where in the brain the seizures were coming from. What we found out was seizures were coming from both anterior and posteriorly, but the central zone, the Rolandic area, was fairly well protected from the epilepsy. So we did a procedure, the subtotal hemispherectomy, to spare the central zone of the brain. And I'll just refer you to this paper from 2019 by a Japanese group, where hemispherotomy using this subtotal technique was performed. And this is the technique. So this is the Rolandic cortex that's being preserved here, that you can see, and over here, and the cuts that are performed to disconnect. And this is what it looks like after the surgery. So you have your frontal basal disconnection here, your posterior disconnection, but the Rolandic zone is left connected, as is shown here. So the cuts are just a little bit different than with a peri-insular hemispherotomy, and this is called subtotal hemispherectomy, which is a very good technique for highly functioning children in whom you don't want to create a hemiparesis. But again, the long-term results are pending. Okay, so that really concludes all I wanted to speak to you about today. I will refer you to a few articles in closing. One is this one, which is the use of diffusion tensor imaging to study patients who have had a hemispherectomy, to see where they might have residual connections and to disconnect them at those sites using neuronavigation. Here's one of our papers on Rasmussen's encephalitis, where we describe our review of numerous children who have had this successful surgery and have done extremely well. Sometimes a diagnosis of Rasmussen syndrome is rather difficult, and you need to go to brain biopsy or wait sufficient time before you can establish the diagnosis, as unfortunately there's no true pathological diagnosis, but you have to put together the clinical presentation, the MRI, and the pathology together to make that diagnosis. And then for those of you who are skillful at this technique, if you're doing this technique in very young children, then you may wish to refer to this paper where we did hemispherectomy in very young infants. All of these children, I believe, were under 6 months of age, and it's a challenging procedure in this particular age group for a variety of reasons. But I would recommend to you that if you're planning on doing one in a young infant baby, that you refer to this particular paper. Okay, so with that final list of some references for you, and having given you this image of how to perform a disconnection procedure of the brain, I want to thank you again for the kind invite to attend your online session in İzmir, Turkey. Beautiful city you have, and I'm very happy to visit with you today.
I thank you, Professor. It was an amazing lecture. I have 2 questions for you. First, I want to ask them. What about your post-operative seizure control? Because I think these children use a lot of medicine preoperatively, and after the surgery, you reduce them day by day, or how it is going?
Yeah, so for extensive epilepsy surgery, whether it's following invasive monitoring with subdural grid or stereo EEG procedures, we tend to leave our children on their medications for 2 years after surgery. That said, if a child is on 4 or 5 medications, almost immediately after hemispherectomy, we can reduce the number of medications that they're taking to a fewer number. But we leave them on some medications for at least 2 years. And then after 2 years, we would do EEG, we would see what the clinical situation is like, and we might keep on one medication for many years later, even if it's a low dose. Just from our experience, we know that there are some failures late after hemispherectomy, and I showed you a couple of cases, one 7 years, one 10 years after hemispherectomy, where they failed. And they were off of all of their medications. And to try to get control with medications once they start seizing again is difficult. So we have found that keeping them on one medication and just keeping that going long term can help with the failure rate, and children do better with even small dose of one medication after 2 years.
So if after surgery, if you couldn't have control the seizures, do you reoperate again?
Yeah, thank you. If you have seizures immediately after surgery, that's not a very good sign, and it usually means that something about the child or the procedure you did is not fully determined. So we would do a MRI scan if we have seizures immediately after surgery to see if there's any connection. Generally speaking, we don't operate immediately. We would wait a while and come back to do surgery, let's say within 6 to 12 months, if the seizures are continuing. If you've done most of the procedure but have failed to disconnect everything, you can still get very good seizure control. So it's rare to have significant seizures in the postoperative period after hemispherectomy. It's more common to see seizures in a delayed fashion, in fact, many, many years later. So while we would do surgery, we usually don't do it immediately. We would wait and work up the child, do MRI scan, and find out exactly why the operation has not been successful at rendering the child into a seizure-free condition.
Okay, thank you, sir. I want to read the chat part. There are some questions and comments. Dr. Çağatay Önal from Malatya, İnönü University, Department of Neurosurgery. Dear Professor Rutka, I am appreciated to see you, a great master in pediatric neurosurgery, in our meetings organized by our studio's friend, Professor Suju. I had the chance to meet with your and Professor Carter Snate Tree's team in pediatric epilepsy program in HSC in 2001. I would like to state my sincere thanks to you and the epilepsy team for the education you gave us and for the Canadian hospitality I lived throughout the year 2001. I also would like to state my sincere condolence for Professor Gentil, a meticulous and humble academic giant. Sincerely yours, Dr. Çağatay Önal.
Okay, so I want to say a special hello to Çağatay Önal and to thank him for his comment. And here you can see his nice name on this very important paper that we published when he was a fellow with us at Sick Kids Hospital on complications of subdural grid monitoring with Dr. Carter Sneed and myself, but a very, very good paper here. This was a technique that we used back in those days, and we're still using it time to time today, of course, subdural grid monitoring. And some complications that arose after monitoring, as you can see here. But this technique, now we've changed mostly to doing stereo EEG technique, as I'm sure in Turkey you are doing the same. But to Dr. Unal, many thank yous. And also I was very pleased to show the paper that you wrote when you were with us in Toronto.
Maybe Professor Çağatay Ünal wants to speak himself. Nurullah.
Yes, if he wants, we can turn on his microphone.
Hello, sir. How are you?
Çağatay, nice to see you. Yes, very good to see you again.
Thank you very much.
How's your
sir.
family?
Yeah, just fine, fine, sir.
Good.
Thank you very much. And we learned a lot from you, Professor Humphreys, Professor Drake, and Professor Dirks during the department. And I would like to thank you very much. Thank you very much, sir, for your assistance.
Thank you, Çağatay. Nice to see you again.
Thank you, Professor Onal. Dr. Edwin Vasfi from Bulgaria, Varna. My question is about the future of that kind of techniques. What do you think about the future of that kind of surgery? Is it going to evolve with the evolution of the technology? Do you consider less invasive techniques like vagus nerve stimulation and etc. for Sturge-Weber, hemimegalencephaly, Rasmussen syndrome? Do you think that radiosurgery will have a place in treating this kind of conditions? Thank you for the excellent, high quality presentation, he says.
Yeah, thank you very much for that question. There are reports now of robotic and laser approaches for hemispherectomy. You may have seen these, and also endoscope assisted. So we now have a laser at the Hospital for Sick Children. We have not done portions of hemispherectomy yet with the laser, but a lot of groups are using it for corpus callosotomy. At this stage, it's technically possible, but it takes actually a lot more time to do laser callosotomy than to do it open, in my opinion. Robotics are evolving. We have a robot now at Sick Kids, and I suspect that for portions of a hemispherectomy, we might be able to evolve to a point where we're using minimally invasive techniques and strategies to do a portion of the procedure, or maybe the whole procedure subsequently, without having to do craniotomy and these big procedures. So I think it's coming. For some children, yes, we have vagal nerve stimulator. One of my colleagues is doing deep brain stimulation. But for true hemispheric catastrophic epilepsy, hemispherectomy is a very, very good procedure. You could see the results, 80 to 90% seizure freedom. That's a very good result. And it remains yet to be shown that minimally invasive surgery will approach those results. But let's face it, in all of neurosurgery, everything is becoming minimally invasive. As far as radiosurgery, I would say probably not yet a good idea, especially in young children, given the harmful effects of radiation treatments. But laser, endoscope, robots, I think all those are possible.
Okay, thank you, sir. Dr. Nurul Huda Maria says deep condolences for respected Professor Gentili. Thanks for the wonderful lecture, sir. What's your kind view regarding responsive neurostimulation for epilepsy? Thanks for the amazing lecture, sir. She says.
Yes, thank you. Great question. Unfortunately, so far in Canada, the responsive neurostimulation is not available. So it is in the United States. Maybe it's available in Turkey or in Europe in some places. But as yet, we don't have approval. But I think it has a certain role to play especially for those children that have Rolandic epilepsy. So just give me 1 second. I'll pull up a paper that we wrote a little while ago.
Okay,
And
sir.
you can sort of, yeah.
Dr. Ahmet Mati says, great lecture. Thank you, Professor Rutka.
He is from France. Anyway.
Okay.
Okay, I'm going to show you this one thing first. This is Rolandic epilepsy, and I think that the responsive neurostimulation, this is the type of epilepsy that in the future may be good for RNS, or responsive neurostimulation. So we did a lot of surgery in the old days to treat epilepsy that arose from the Rolandic region. And we would do large resections like this in the Rolandic area, as you can see. But it probably nowadays, for quality of life and outcome, if you can put a responsive neurostimulus here, as opposed to resecting that area, the outcome will be much better and for the children. So these types of resections in the Rolandic area, although it was very useful technique in its time, I think responsive neurostimulation will be much better in the future.
Dr. Musa Çırak from Istanbul, thank you for your excellent presentation, he says. Dr. Ceren Günbey, I wonder your opinion about the cases suitable for hemispheric surgery with seizures arose from the affected hemisphere on phase 1 investigations, but also had contralateral hemispheric impairment. Thank you very much for the wonderful lecture.
Yes, thank you. So this is always a challenge when you have epilepsy, primarily one hemisphere, but the other hemisphere is not normal. And we do not obviously do bilateral surgery, but this is sometimes called palliative surgery, where if you have evidence that one hemisphere is primarily involved, but there's still some disease or epileptiform activity in the contralateral hemisphere, you can do hemispherectomy, but the outcome will not be as good as if the other hemisphere is normal. So the group from the Cleveland Clinic published on their outcomes, and you can refer to their paper, with palliative hemispherectomy, where the contralateral hemisphere was also involved, but the results will be in the order of 40 to 60% instead of 80 or 90% success rate. And sometimes, as you know, Sturge-Weber will have bilateral disease, obviously, and we've done some cases of Sturge-Weber bilateral where one hemisphere was more involved than the other, but again, the outcomes are not nearly so good as if the other hemisphere is normal. But very, very good question.
Thank you, sir. Dr. Nurul Huda Maria from Pakistan. Sir, can promotion of sports be really helpful in neuroplasticity in patients post-hemispherectomy?
Yeah, thank you. So I showed you that one child who was water skiing, skiing, was doing waterboarding, everything. So I think the more that can be given in terms of physiotherapy, physical therapy, exercising, the better. Unfortunately, some of the children are very delayed and aren't going to be at that level, but many children with Rasmussen encephalitis can be benefited from a very active physio and occupational therapy program.
Okay, thank you, sir. Dr. Miroslava Marushenko, I think from Kiev. Dear Professor Rutka, thanks for wonderful lecture. Best wishes from Kiev, he says.
Yeah, thank you so much. I often go to Ukraine for helping with surgery and lecturing. And I know Ukraine is just north of Turkey. And I know there's good collaboration between Ukraine and Turkey. So thank you, Miroslava. Very nice to hear from you again. And I hope to see you in June when I come back to Ukraine, as long as the pandemic is okay.
Dr. Nurul Huda Maria, she shares a link and says, yes, sir, I wrote a letter on one paper as well. Thanks a lot, sir, for your kind, elaborate answers. I am deeply honored and pleased, she says. Okay, I don't see any other comment or question. Professor Suju, do you have any other word?
I want to thank again to Professor Rutka for accepting our offer to speak in İzmir Online Neurosurgery. We are lucky today, and we hope to see each other in a not far future. In İzmir, also again, we will be happy to see you in İzmir, Professor Rutka.
Okay, thank you very much for your invitation. It was great to speak to you today. Everybody stay safe and well, and we hope we can see each other in person in the near future.
We hope so.
We hope so, sir. Thank you a lot.
Thank you very much.
Bye-bye.
Bye.